So, good afternoon, good evening, everyone. It's really a great pleasure to have you here, finding the time for joining our seminar. The title is Herpes Virus Infections After Heart and Lung Transplantation When CMV and EBV Go Rogue. My name is Christine Falk from Hannover Medical School, and I'm really pleased to be the chair of today's webinar. As many of you know much better than I do, transplant recipients, especially those who have a lung or heart transplantation, really often suffer from cytomegalovirus infection. And CMV can have a negative impact on outcome that has been published in a large study cohorts. And ultimately, it may harm the chances for survival both of the graft and the host. And then there is another virus, also a herpes virus, Epstein-Barr virus, that is frequently triggering problems. And it's causing, because it's infecting B cells, post-transplant lymphoproliferative diseases. And these are major complications after transplant recipients, especially in children. So the management of PTLD is still problematic due to a lot of different difficulties with diagnosis, but also prevention and also treatment. So in this ESOT BioTest webinar, you will learn about the burden and also the common features of infections with CMV and or EBV after thoracic transplantation, and also about the center-specific experiences in the clinics when managing CMV or EBV. So I'm really pleased that I will be joined by two expert speakers. And the first speaker will be Dr. Paolo Solidoro from the University of Turin in Italy, and he has a lot of experience. He's from the School of Medicine in Italy, in Torino. And then we have the second speaker, Professor Markus Barken from the University Heart and Vascular Center in Hamburg in Germany, who also has a lot of experience with viral infections, and he will give a talk on EBV, the baby brother of CMV. So each presentation will last about 20 minutes, that's at least the plan. And then there will be a question and answers session afterwards when both presentations will be complete. So to facilitate your questions, I think the best way to do that is to use the chat option so that you can have on your screen the option to type in your questions, and then we will discuss them afterwards. And to really, we would like to encourage you to write your questions already during the presentations. We will read them and also collect them and then refer to them after the presentations. I will read out those questions and then they will be answered by the speakers, and we will see how lively the discussion can get in the Zoom format, but I think we have a good chance to do so. So once the Q&A will occur after both presentations, it's really a good idea if you type them already during the two talks, because then these are fresh ideas and they would be really the best to see what your thoughts are and what your questions are. And so we will do the best to address your questions in the time we have provided after the two presentations. So as you have seen from the invitation, the webinar is sponsored by BioTest in an unrestricted educational grant. It's important to mention that. And now you're welcome to share details of this presentation responsibly with due credit to social media. So you see here the Twitter, which is one option for you to do. And so this was sort of all about my introduction. And without further ado, I would like to introduce the first speaker, Dr. Paolo Solidoro. He's already there, and we are really curious to see what your presentation will give us in terms of insights into cytomegalovirus in thoracic transplantation and the experience from the Italian group in Torino.
Thank you, Christine. Thank you very much for the kind invitation and the presentation. I'm very happy to share with you I'm very happy to share with you the presentation of the results of our studies in the past about the management of CMV. Obviously, I have not a conflict of interest, and you can take pictures if you want to share to see, just because we are talking about data already published and so already public. What I wanted to talk about are different topics CMV and the role in acute rejection and pneumonia, our management of prophylaxis, the role of EBV, just a few words, probably to open the street, to open the way to Marcus, which are the mechanisms of acute rejection and pneumonia, the cellular immune response, and our behavior, which is a tailored management and the results of our behavior. About CMV, the role of CMV in acute rejection and pneumonia is well known. There are many publications. I don't want to talk too much about the mechanisms of acute rejection, but I'd like to show you, as in our studies we have seen that when we find acute rejection, we have a percentage of CMV significantly different and higher than for HHV6, HHV7, and EBV, and the percentage is about 70%. So when we have acute rejection, usually in many cases, we have also CMV to manage. Why prophylaxis or preemptive therapy? We can say that both types of management have advantages and disadvantages. About prophylaxis, the main advantage is that the clinician can some way forget the problem, but this is a short forgetting the problem, because there's a big incidence of late onset CMV disease, and there is a delayed priming of T-cell immune reconstitution. This is a big disadvantage, and other disadvantages are mainly related to the costs, I mean the economical costs, and are related to the organ costs, I mean kidney and bone marrow side effect. On the other side, the preemptive therapy needs a strict control, strict follow-up of CMV reactivation, and there's not an univocal agreement about monitoring specimen and cutoff of these specimens. Just to make an example, in 2007 we used so much the shell vial culture for the detection, because we were convinced, and probably we are yet convinced, that the positivity of a shell vial is much more efficient than a PCR, because having a virus is different from having an active virus, and probably shell vial gives us something more in activity and virulence. What we tried to understand was to study two different cohorts in 2008, two different cohorts about prophylaxis and preemptive therapy. The first cohort, Wait and Treat, was a cohort of 25 patients who received acyclovir for 12 months, and ganciclovir, just in case of positivity of shell vial viral culture on BAL. The second group, the second cohort, was 21 recipients receiving valganciclovir or ganciclovir prophylaxis from 21st day after transplantation for 3 weeks, and in case of positivity of shell vial, and an additional prophylaxis, longer prophylaxis, with CMV immunoglobulins, the old dosage of 1.5 milliliters per kilo, which is the actual 0.75 milliliter per kilo in the first month, and 1 milliliter, the actual 0.5 milliliter, for the following month, and were administered at days 1, 4, 8, 15, and 30, and then monthly for 1 year. And the results were very interesting on the point of view of lymphocytic bronchitis, bronchiolitis, because we had important reduction of bronchitis, 2% versus 11%, and the results were more interesting for acute rejection because we had a reduction from 17 in the group without prophylaxis to 6%. And in a logistic regression reduction in prevalence of acute rejection, we had an odor ratio of 3.25. So our conclusions were that our data suggested the efficacy of combined CMV prophylaxis to prevent acute rejection and lymphocytic bronchitis, bronchiolitis, who were two risk factors for chronic rejection, and the possible role to reduce the trend towards CMV pneumonia because we were not yet statistically significant on pneumonia, and we saw a reduction of EBV infection. What about EBV infection? We found in our BAL just the 6% of positivity, just to give an idea. For other groups, in the same period, there was a publication coming from Wien in 2007, and the prevalence in BAL was 43% versus our 6% in Turin. But what was really interesting was the problem of co-infection. You know, co-infection of EBV and CMV are very dangerous for development of CMV pneumonia and EBV-related problems. Marcus, I'm sure, will explain to you much better than this, but in our cohort, the percentage of co-infection was the 0%. You know the incidence of PTLD, and so this reduction of EBV could be absolutely a good result to have a reduction of risk of lymphoid disease. I told you that we didn't have a good result, statistically significant, about CMV pneumonia, but we needed just some patients more, 33 recipients versus 21 in the previous study, with the same schedule, to have the same number of CMV pneumonia at the first month. This is a problem, this is a situation that will last in our group in the next years. There's no great difference with our prophylaxis in the first month, but from the first month we have no more CMV pneumonia. I mean 1% versus 6%, and even in the second year without prophylaxis, the number of CMV pneumonia didn't increase. And so the percentage was 1% versus 6.5%. So, conclusion, this data seemed to confirm a pivotal role of CMV in modulating acute rejection and infection, and so prophylaxis was a strong effector to reduce infection and reduce acute graft rejection. Next step was to try to understand if we could use a lower number of therapies with antiviral drugs because of positivity of BAL to understand the cases in which the BAL was just positive infection or the BAL was positive because there was an active role of CMV in producing infection. What could be the mechanisms of this regulation, acute rejection and infection? Probably when we have an increase of viral load, we have infection. When we have an increase of immune response, we have rejection. This is the comfort zone with a Gauss curve with a particular shape, but when we use immune globulins, we reduce the number of infection. we have a down regulation about the immunity, and probably the comfort zone becomes wider, with the curve wider and a bigger number of patients in good health without infection and rejection. Another important topic is the cellular immune response. I remember that in April 2014, there was in San Diego a symposium at 7 o'clock in the morning talking about CMV at the International Society of Heart and Lung Transplantation Congress. When we used to go to Congress without a webinar, without COVID, there was a CMV infection in lung transplant recipient symposium. Are we ready for personalized medicine? Okay, perhaps we were already ready for the personalized, because our very strong virology prepared a handmade ELISpot with the study of interferon gamma production by stimulated lymphocytes with the specific peptides for CMV, and they developed the qualitative result, responder versus non-responder, and the quantitative results with the different spot-forming units. And so they published this effect, this important way to monitor infection for EBV and for CMV, but the results can be summarized in this publication, in which we found that the temporal profile of infection, duration of infection, and incidence, occurrence of organ disease, CMV organ disease, appeared related to CMV responder status of the patients. This is a topic not directly related to our day, but I want you to remember that we saw that everolimus immunosuppressive regimen reduced the number of episodes of CMV positivity, and so in case of CMV positivity, everolimus can be used too. So we tried to propose a tailored management. This is the tailored management. This is an algorithm that seems to be difficult, but it is probably in the practical days, in the clinical practice. We make a prophylaxis, as we said. Then we make a follow-up with transbronchial biopsies, bronchoalveolar lavage at month 1, 3, 6, 9, 12, 18, and 24. If we have transbronchial biopsy positivity or pneumonia sign of symptoms, we perform antiviral therapy. If we have just specimen positivity on BAL, we don't treat all the BAL, just to reduce the risk of economical costs and organ costs. But we treat just non-responders. For people responders, we have a strict follow-up. And for people with frequent specimens positivity, for late non-responders, we use a long-term antiviral therapy like the one proposed by guidelines for 6 months and 9 months, and we use at least everolimus immunosuppression to reduce the risk of infection. Now, this could be an original idea, but we have to demonstrate that it is useful. And so we have just published last year, a 1-year follow-up for 43 lung transplanted patients for a total of big number, 1,134 whole blood and 167 bronchoalveolar lavage. We have this schedule, which is the same as we described in the first slides, and so I don't state much on this schedule. But what it is important to say is that we used antivirals, drugs, I mean ganciclovir or valganciclovir, just in case of pneumonia, in case of shell vial isolated from BAL more than 10, more than 10,000 CMV DNA copies on BAL, and more than 100,000 copies per milliliter in blood. Our population, about serostatus for CMV donor recipient, is a classical population with a 63% plus plus, 21% plus minus, 14% minus plus, and 2% minus minus. It's very important to think about this population because all the difference we can find guidelines about the terms of antiviral therapy in our courts is not so clear. We are going to see much better in the next slides what I want to say. About CMV pneumonia, we can see in the population and general population articles in literature an incidence ranging from 4% to 32%. In our population, we recorded just 2 cases of CMV pneumonia for an incidence of 1.2%, 1% lower than the rest of population. And what I wanted to say few seconds ago is that both cases were D plus R plus patients, and both patients were within the first 30 days after transplantation. Probably this is not a problem of, how can I say, prophylaxis. This is a problem of strong immune suppressive regimen we have in the first transplant month. Completely different is the situation about the bronchoalveolar lavage, because we found until 30% of incidence of pulmonary infections, and 69% of these patients experienced at least one episode during the first year. So in the BAL we found a lot of positivities. And even in this group, the D plus R plus group was the most represented one. And so the great difference between the risk seems to be not so important in our cohort. About the percentage in our studies, this positivity is lower in other studies, but when other studies are not using a long prophylaxis, the incidence increased in that groups too, ranging from 10% to 64% of positivities. And so it seems to be quite clear then the positivity on BAL depends on how much drugs you use. Lesser the use, higher is the percentage of the incidence. About viremia, we found the positivity just in 3% of our group. And so we can see that the incidence of CMV viremia is considerably lower than the incidence of positivity on BAL. When we use an antiviral treatment, we use antiviral treatment only in patients with positivity on BAL, but with a low response to CMV. So the balance was in the hand of the cellular immune response. In this case, just 62% of cases with asymptomatic CMV positivity were treated. So 40% were just followed up to see not a positivity of organ disease. Probably because of the low load of antiviral drugs, our discontinuation rate in our cohort was really low, just 9%, because the quantity of drugs was lower, just for 1 month in a limited number of cases. Anyway, 19% of our patients needed at least 1 cycle of therapy for 1 month, or better, prophylaxis of clinical manifestation of infection. The last point is the ELISpot for CMV. We have used this to decide our therapies, and what is really interesting is that all responders at ELISpot maintained their status. Most non-responder, 12 on 13, switched to a responder status. So our patients became active in the immunological response. Probably because there's a little but constant level of circulating CMV, not enough to create a sort of illness for organs, but enough to allow the immune system to respond. So, in conclusion, our tailored approach allowed a very low number of CMV pneumonia, just 2, both the R++, both just in first month. So, how can I say, we can forget CMV after the first month with this sort of prophylaxis. This prophylaxis, based mainly on immunoglobulins, allow the development of a natural immunity. And CMV ELISpot is the balance to decide the difference from a prophylaxis and the sort of preemptive behavior, trying to show early activation before coming to real problems to organs and to illness of organs. So in conclusion, I hope to have explained in a good way the approach from acute rejection to prophylaxis to a little number of slides for EBV, to mechanism, to the role of cellular immune response, and to explain an original tailored management with good results. And so I thank you very much for the attention, and I'm ready in case of question.
So thank you very much, Paolo. This was a great insight into your experience, and I think we already learned a lot on the donor-recipient status, on the timing, on the prophylaxis, and the importance to study the T cells. But before we come to your question, we would like to hear the second talk by Markus Barton. So Markus, without further ado, I would like to ask you to share your screen and to give us your talk on the EBV side of it, so that we learn something from the other virus, and then we will see that we can combine the questions. I just would like to encourage the audience to use the question and answer possibility in the middle of your screen on the bottom, where you can type in your questions. So far, I don't see some. Maybe the ESOT hosts might see some, but it would be really nice. Here the first question appears. So I will read them, and then we can discuss them later on. So Markus, this is now your chance to give us your insight into EBV. Thank you.
Yes, thank you very much, Christine, and hello from Hamburg. And yeah, this is my conflict of interest. And for me, it's the same for Paolo. You can Twitter or what else you like to do is social media with my presentation. And I was asked in these times, because we have this webinar, how it looks like in this, all the transplant numbers in Germany. I think this looks okay for the heart. And we could a little bit increase the same for our center. We had an increasing number of heart transplants, so no restrictions. And if you compare over the years, the same month from January to August, that was our luck. For lung, it's a little bit lower, but maybe that's due to the, of course, COVID affecting the lungs and the complicated diagnostic, which is preferred. And I also like to show you the data for, for the kidney and for the liver. Kidney, the decrease in the kidneys belongs to the lower number of living donation, and for the liver it was similar compared to the years before. So we are lucky in Germany, but it reflects the lower number of infections in the whole population compared to other European states. So coming to the main point, and if the title is quite funny, the baby brother of CMV is EBV. And if you look at the international registry data from our society, you can clearly show the cause of death. It reflects why this title is correct. As we there's a special for CMV and the prognostic and the relation for CMV cause to death, but the baby brother is in here, yeah, must be in here. And so this is very seldom, and the percentages are very low. So what we know from EBV and EBV infection, we all know that, oh, there's something that's called PTLD. So this is also a fact. This is second highest malignancy after skin tumor, after heart transplantation, but you see the numbers are low and they keep low over the years. So because it's very seldom, I like to go a little more deeper into the EBV and starting really at the life cycle. And there's two things. Infection starts in the oropharynx. The epithelium cells could be infected, but also naive B cells. We have so-called the lytic phase and EBV infection of naive B cells in the latent phase. That could cause 3 programs, growth, default, and latency, and where the virus can persist lifelong. But if there could be a reactivation after circulating of the B cells into the Waldeyer ring, and so differentiate in plasma cells, which then against in the lytic phase and could be infect the human being. And what we have in a transplant situation, that the so-called the cytotoxic T cell, they control this growth program. And if you inhibit these cytotoxic T cells, you let these EBV infected growth B cells, they grow and they can differentiate in PTLD. So we decide just this briefly over this 2 strains of EBV. EBV strain 1 is more pronounced in the United States and Europe, and there's another strain in the rest of the world. And transmission, as you know, is from person, salvia, sexual intercourse. And the shedding of the virus could be for decades, right? Most of the infections are subclinical. That makes it really difficult for us clinicians. And there's also a socioeconomic, due to socioeconomic status, a difference between the seroprevalence, which is much earlier in the developing countries compared to the industrial nations. So, organ transplant, they can be asymptomatic, they can present symptoms like we have in mononucleus rhosis. We know this from the younger patient, kissing disease, we call it, and this enlargement of the lymph nodes, and that could be a life-threatening sepsis-like presentation, but this is very rare. But also EBV is associated in organ transplant with gastric carcinoma, smooth muscle tumors, and other symptoms like Guillain-Barré syndrome. So we have to keep this in mind. And I pick up not only heart studies, I always like to look in the other organs, learn from other organs. And I think even here, it's much more important to look at other organs because we need all the information we can get how to handle EBV. And I like to share results from studies in kidney transplant. They measure the viremia of EBV regularly every 2 weeks or 3 months and so on over 1 year. And they treated the high-risk recipients which got a donor positive, EBV positive organ with immunoglobulins and antivirals, and they also prescribed ATG, and instead they initiated induction therapy with basiliximab. And you see here, there was in this was a large number of patients that have a persistence over like till 6 months or over 6 months viremia. And here patients with ATG use, they had a higher number of EBV positivity. And one of the interesting findings of this study is by measuring EBV, they did not find any PTLD, but they found that patients with EBV viremia had a higher incidence of rejection. Other studies showed this also. This we have to keep this in mind that it could be happen. But this might be, like the authors discussed, and not a direct effect. Maybe is this a more indirect effect, or is it just the clinical decision which are made by the detection of the virus? That's something. But we have to keep this in mind with EBV that could be lead to acute rejection. And one thing Paolo also already mentioned is what is the other brother doing in this, the co-infection with the CMV. And in this study, they found CMV disease was slightly more frequent, but this was not significant with in patients with EBV reactivation. And the third topic is that they found in EBV positivity patients a more opportunistic infection like bacterial infection, CMV disease, or other herpes virus infection like zoster or herpes simplex. I think that is also another thing we have to keep in mind. What we also know, of course, from CMV, but also the brother has a same possibility to harm with opportunistic infection. And we also talk about PTLD and EBV, but we have to keep in mind that there are other tumors associated with EBV. like here, and I show you in this slide. I don't go in this detail, that is too much. So what are the incidents? I showed you heart, it's low, lung, it's a little bit higher compared to the other organs, kidney and liver, and of course of the lymph nodes, it's higher in intestinal multivisceral transplantation. In kidney transplantation, it was found as up to 12-fold higher rate of non-Hodgkin lymphoma to a control population. And we know that the PTLD has a bimodal peak with a very highness in the early years of transplantation, and the second is after the 5th year of transplantation. That is for all organs. And this is the set. You can see here what is the difference between early and late PTLD. Just to mention, in the early, it's mainly in the high risk group, recipient and negative, high use of induction therapy, maintenance immunosuppression with Chacolis mycophenolate. It's given mycophenolate. I found other studies that showed there is no effect. This might be, this is the most common used immunosuppressive regimen, Chacolis mycophenolate, so that might be more belong to the tacrolimus. So it appears early, as I said, and this is involves the allograft. This is one, as we heard from the kidney study, is more polymorphic, and it responds to reduction of immunosuppression. That is also my experience with early PTLD. Compared to late PLD, that is in older patients and monomorphic, and they're more resistant to reduction of immunosuppression. So talking about early and late, now we show you some about the literature for the organs, risk factors. This is clear intensity. I said that treatment of acute rejection, of course. This is also something, HLA mismatches is one thing, and we have to keep in mind. And the other thing in how we handle and diagnosis and staging is for the therapy, it's very important, the classification, and common use is the WHO classification, which differentiate between the early lesion, monomorphic, is it a B cell or a T cell, or more a classic Hodgkin lymphoma. This is for the therapy very important. So what we have in clinical symptoms depend what I said, the transplant organ, time, of course, this I said, be symptomatic, but other organs are involved for the gastrointestinal tract, the lungs, skin, liver, central nervous system. It's only after kidney transplants, and in the allograft, they could lead to graft loss that I said before. So altered mental status could be PTLD with a poor prognosis, gastrointestinal involvement, weight loss, bleeding or obstruction, perforation, or these symptoms could be belong to a PTLD. And this is how it looks like, involvement in the lung, in the liver, or in the stomach. So I just show you a study from a single center study, large study from Sydney in heart, lung, and lung transplant a patient with PTLD. And you see here the incidence was over the decades lower because we lower over the decades the immunosuppression. Look here, we have early, more on the late, 2/3 on the late, so-called late PTLDs, And if you look at the organs, that's quite interesting. In heart, they found more the late PTLD compared to lung, which is almost equal early and late in this. B-cell lymphoma in 2/3 of the patient as a histological classification, more monomorphic, and most of them was EBV positive. For the treatment, first reduction of immunosuppression and then combination of these chemotherapy or rituximab. We come to this a little bit later. Good. We have to keep in mind allograft rejection. If we reduce the immunosuppressive regimen, here we have in heart much higher rejection if we do so, and this is causes of death. This is also what is our experience. This is mortality is very high. If you see here in this graph. And then they did analysis. They found in UNIVAD analysis good prognosis factors, complete response in first line. This same experience I have, poor prognosis, older patients, if you have bone marrow involvement, and hypoalbuminia. I think it's always something, and advanced stages of the Ann Arbor classification. And if you do the multivariate analysis, they found the bone marrow involvement hypoalbuminia as really markers of advanced disease with a poor prognosis. EBV positivity, I told you, but it was not found to have a prognostic significance. Another heart transplant study, single center from Heidelberg, Germany, and they had a large study, different immunosuppressive regimens over time, starting with cyclosporin, azathioprine, and then tacrolimus and mycophenolate, but also very early use of mTOR inhibitors. And they found the PTLD in 15% in their study group, but interesting, no difference. And this is what we have to my mind between the positive CMV or EBV serostatus. No difference in tumor PTLD or patients are not. So, but they
Marcus, it looks like the connection is somehow stuck.
In a French registry study of over 200 cases, and this is in renal transplant, early PTLD, better prognosis, graft PTLD, better prognosis than other locations, single site better than multiple sites. So, and they found a hepatitis positivity was a co-founding factor and associated with a poor prognosis. And this is the recipient viral status within EBV and CMV and positivity, which did not show any difference. So the zero status, again, no difference here. Good. And then another question is, how do we monitor? Which do we use? Whole blood, plasma, serum, peripheral mononuclear cells. There is no, there's really a difference in which assay is the best assay. Most of them may use a PCR whole blood. And some are, we also can use DNV viral loads, but yeah, cutoff values are also differ the same for CMV. There's a center specific based on the experience, and of course, Paolo said is we have to do individualized medicine and adapt our cutoff to the patient and to the risk of the patient to get virus infections. So I go not in detail, but this set monitoring for response, monitoring, of course, the high risk patient, donor positive, recipient negative, but not mismatch is discouraged. This is for all organs. How do we diagnose once we have EBV viral load? Radiographic imaging, it's for localizing and staging, CT, MRI, PET-CT, it's very common, but crucial is also the tissue biopsy for the diagnosis, and then for the treatments, the morphology, the immunotype, the histology, and to differentiate if the CD, for example, CD20 positive, the B cells, or is it less common, the cytotoxic T cells, epitopes. And this is crucial for our therapy. And
Marcus, I'm sorry, can you have a look at the time? Because we would
yes.
like to discuss a bit and see that you can summarize. That would be very nice.
Yeah, okay.
I'm sorry.
Okay, I skipped this. PTLD, immunosuppression, increased risk. Anti-ATG, for example, but when we know belatacept has this risk warning, no with the IL-2 receptor blockers, and for mTOR inhibitors is conflicting results. So this is nice summary slides how to treat in the algorithm. And I can just recommend if you have more interest to this in this paper. And one thing I would talk about the immune globulins. We heard from one study this was an effect, and here from the collaborative transplant study register, large studies, they compared antiviral with immune globulins, and they showed after the first year patients who received immunoglobulins had a lower incidence of lymphoma in kidney transplants. That was not hold for after 5 years, but after 1 year, there was a significant difference. And then they measured the 3 different anti-CMV immune globulins, and they found a high proportion of antibodies against EBV in this humanized plasma. And I think found quite interesting, and some good experience also with immune globulins treating BK virus heart transplant, BK virus infection after heart transplantation. And this is one Peter Jaksch found also in Vienna. Patients in his cohort retrospective study treated with prophylaxis of immunoglobulins for 4 weeks, and he had a very, very low incidence of PTLD, 1.5% only. This was astonishing because he had a typical lung transplant recipients consisting of young cystic fibrosis patient with induction. They need a higher immunosuppression and also induction with ATG. So there might be something, and I want to go in much detail about the mechanism of action, but immune globulins can do it. And just let me summarize what I said, how we do it in Hamburg. If we have symptoms, if we have copies, then clinical assessment, lab values, radiographic imaging, otorhinolaryngology. We have to regularly see the patients and measure. If we have any suspect of PTLD, then it goes further. We work together with oncology department, tissue biopsy, and we do more staging than with PET-CT. And for us, is reduction of immunosuppression. The first step, switch to mTOR. We don't need it. 90% of all other pediatrics and adult patients are on mTOR. And we add also always immunoglobulins. Rituximab combined with serotonin, but this is something we discuss in an interdisciplinary team with our oncology department. And so, yeah, this is the big brother, the baby brother is EBV. I think this is a rare incident, but it's we have to have in mind, and we have to think to monitor, especially the high risk transplant recipients. And for me, if we have detected PTLD, then interdisciplinary team approach is crucial. Reduction of immunosuppression and adding immunoglobulins, and then rituximab is a goal. But of course, we have to find optimal strategy for prevention of PTLD to prolong graft-allograft survival, and that's it for me. Thank you very much.
So thank you very much, Markus. This was really a great insight into the importance of EBV, whether it's the big or smaller brother. I think we really got a very good impression that it's important to follow up on Epstein-Barr virus and to be aware of PTLD complications. We got 5 minutes more because we are running a bit late, so that we have a couple of minutes to address questions. And I should not forget to mention that if you have questions that we cannot address now, there is the Ask Me at esot.org possibility, so you can type your questions and you get answers via email from ESOT. But I have 3 questions. The first is from Lorenzo Zaffini to Dr. Solidoro, and so it's a great presentation, I would agree, and also Markus. Do you know if the administration of IgG against CMV will modulate the T-cell responses in terms of interferon gamma production? So it's the question of interference between immunoglobulins and T-cell responses. Paolo, what would you say? Did you have experience on that?
No, I have not a direct experience about basic research. I can say that immunoglobulins seems to reduce in complex the number of infection, probably can reduce with the feedback, negative feedback, all the immunity, but I have not basic research to confirm that.
It would be rather unlikely, I would say, because the antibodies should not negatively regulate T-cell responses, but I do not have a paper in mind that shows that, but maybe sort of one should look at that in the future just to make sure that there is no interference, which I again would not expect. I'm also a big fan of ELISpots, but I know they're really hard to harmonize and establish, so it will be probably difficult to find out, but someone should do that. The second question is from Davide Abate, also to Paolo. What is the rate of drug-resistant CMV in lung transplants? Is the CMV T-cell immunity with the ELISpot relevant to clearing drug-resistant CMV strains? What would you say, Paolo?
This is my impression. Absolutely, my impression is that we use a low load of drugs, and so we have less resistance to CMV. And when we treat CMV positivity or CMV pneumonia with our drugs, we have not resistance, and they respond. I repeat, the problem is that in our group is just in the first month, and so we have no more pneumonia after the first month. In that period, we have no problems.
Yeah, so I think the timing is really crucial here, and the question, when do the T cells control? And I think the timing is a reflection of the power of the T cell response. Would you sort of agree to that?
And I'm sorry, I don't understand the question.
So
Can you
T-cell
repeat?
responses, the question is, at which time point are the T-cell responses really controlling CMV reactivation or infection? I think this is that the T-cell response is one important modulator, not alone, but one important factor in that. Would you also agree?
Yes, I agree, but I have not idea about exactly what time we have a complete response. When we have a complete response, probably it's useful to limit the infection, but we need a positivity of a spot.
Yeah. So then I have a question from Thomas Kledal to Markus. With the clinical data in mind, do we need a drug targeting of EBV, and what would be able or should we be able to do? That's a very good question, because this virus is a transforming virus and it has the additional complication of transforming into lymphomas, as you showed. Markus, what would you say?
As a doctor, we like to have drugs to play around. That's for sure. What I think we have to be aware, the awareness of EBV is not as a baby brother, still it is, and the awareness is not great enough. So we have to monitor in more specific, like we do it for CMV on a regular basis. I think this is the most problem we have. And then we have to adapt our immunosuppression regimen if it pops up. And we have the awareness. This is really this is the first step before we have a new drug. Would be nice. That's for me, I think.
Yes, I would agree. Also, Britta Meka-Koloff, she's leading the transplant PTRD registry for pediatric transplantations, as you know. She will also agree, and there are some kind of T-cell ideas arising to apply T-cell therapy, which is a really big topic, but it's of course very difficult to perform, but there will be something on the horizon probably. And there's also a very important question to Markus. What is the role of photopheresis in patients with EBV and CMV? Do you want a short answer if possible? And then I have a really important question to Paolo then, the next one, also related to EBV.
Yeah, I think that was in my mind. I skipped this. I left it out, the photopheresis. But yeah, it is. I think it is. We talked about this, Christine. Now, for CMV, I have very good experience with the low incidence, and we know this from study that's a lower incidence if you treat these patients with photopheresis, and I could imagine that would be the same for EBV, but I have no data on this. I have to look into this in my patient. I treat it regularly with photopheresis if they really have a benefit in terms of lower incidence of PTLD or
I think studies on the mechanisms of photopheresis would be important, because if you don't know how it works, you will not be able to really give a clear answer, but we discussed that. But there's a really important question from Stefano Pavanello, and the question is to Paolo. So about the treatment of EBV in Italy, the impression also from the talk is that in USA there might be more attention to the importance of Epstein-Barr virus also in research than in Italy. What do you think? And would you then encourage also, as Markus really proposed, to have EBV on the screen?
I can say that the same schedule and the same algorithm proposed by Markus is a little bit, perhaps a little bit different from what we use, but I think is similar, because in case of EBV, we behave in the same way. We try some antiviral with low success, because I really don't know what is the best antiviral for EBV. Probably no one knows what is the best one. But we help our patient with immunoglobulins because there are big titles in immunoglobulins for EBV, and just then we reduce immunosuppressive agents, and we use everolimus in the place of mycophenolate. Okay. And this is our behavior, and we follow up with a great attention EBV.
Okay, so that's very good to know. I'm very sorry we have to close the session. I think there are more questions, and I would like to remind you to submit them to askme@esot.org. you will get answers to your questions. I think that's a lot to discuss in the future. I think there were 2 great talks. I learned a lot. I think you also did. And there might be some continuation in the future. You see here on the slide the askme@esa.org. I thank you all for your attention. Stay safe. Stay away from SARS-CoV-2. We didn't talk about this virus for good reasons. But please stay safe, stay healthy, and let us meet again at ISHRT, AGT, and other meetings once we are through this pandemic. I thank you very much, all you, for your attention and the speakers and your questions. Bye-bye, and
Bye-bye.
as soon as possible again.
Bye-bye.
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 Bye.